Well, good morning, everyone. Welcome to Grand Rounds. Our speaker today is Dr. David Kendrick. He is founder and CEO of Oklahoma's MyHealth Access Network, which serves more than 3 million patients statewide and provides advanced health information exchange, community-wide care coordination, and a robust decision support platform. MyHealth provides region-wide quality measurement for the comprehensive primary care initiatives, as well as ACOs and value-based payment models in Oklahoma. Dr. Kendrick is chair of the board for the National Committee for Quality Assurance and a board member of the Strategic Health Information Exchange Collaborative. David proposed the patient-centered data home model of nationwide interoperability, which enables secure patient record exchange among states and regions where individuals receive their care. Dr. Kendrick is the chair of the Department of Medical Informatics at the University of Oklahoma. His presentation today is Practicing Person-Centric Medicine in a Doctor-Centric World, using MyHealth HIE to get the whole story and make a comprehensive plan. Please join me in welcoming my colleague and friend, Dr. David Kendrick.
Thank you, Dr. Alexopoulos. It's such a pleasure to get to present to you guys this morning in this unusual time of Zoom rather than face-to-face. But a lot of what I have to show you today works, I think, just as well over the computer. Please let me know if my audio is not good or if I have any network disruptions. But for the moment, I think things are working well. As in terms of the sort of the ground rules, I guess, for this presentation, this is for you all. So please feel free to interrupt me. And Dr. Alexopoulos, if you see people chatting in questions or raising their hands or something, please don't hesitate to interrupt me. I put together an agenda to cover some material, but no one should feel pressured that we get through all of it. There is a lot to cover after 10 years of work on this project. And with that, I'll just dive right in. Okay, so this MyHealth project has been a labor of love for many in our community, including Dr. Alexopoulos and a number of your colleagues there at OSU, as well as folks from tribes and the health systems and the insurers all across Oklahoma who have come together to build MyHealth. These are my disclosures. Dr. Alexopoulos covered most of those, but I wanted to make sure you had the list. So here's the agenda I put together today. First, just a moment about challenges in healthcare that we're all aware of, the data fragmentation and why do we need health information exchange, what is MyHealth, talks in some detail about MyHealth's new provider portal, care fragmentation alerting, social needs screening and intervention, pandemic, of course, no conversation can happen without discussion of COVID-19, and then how to get involved in MyHealth. So let's start with challenges in healthcare. A bunch of information I'm sure you already know, but MyHealth, the United States spends more than double what every other nation spends on healthcare, and we aren't necessarily getting what we're paying for in this country in terms of life expectancy. And I suspect, and have seen recently in the news, that with COVID-19 and our response to that, that life expectancy is materially affected by that as well. In terms of spending in healthcare in the U.S., there was one moment in time in the mid-90s that you all may recall during the so-called managed care era where healthcare spending leveled off. And then, of course, patients began to be upset that they had lost choice and they weren't able to direct their care as much. And there really was no quality component to what was going on. And so managed care largely, except for Kaiser Permanente and a few other big organizations like that, ceased to exist for a while, and we began to see healthcare costs rise again. But now we're in a new era, starting really in 2008, 9, in that time frame. We began to talk about value-based care and value-based payment models in which not only was cost a consideration as it was in the managed care era in the 90s, but also quality. And so, of course, value is quality divided by cost. And this has sort of become an essential equation for those thinking about how to improve the delivery of healthcare services across a community. And then, of course, with COVID-19, necessity is the mother of invention, and I think we've all witnessed a boom in telemedicine and the use of other, alternative modalities of care delivery, which I think present lots of exciting alternatives and opportunities for those of us in the healthcare delivery space to modernize what we're doing. So, as providers, you all hopefully recognize that there are a whole constellation of complications to what we're trying to do in healthcare. We've got meaningful use, we've got MIPS, we've got ACOs, we've got other alternative payment models. Some in Oklahoma participate in the Comprehensive Primary Care Initiative, and every health insurer comes to us with a different and new program. And in addition to that, we've got our own internal quality to keep up, and all of our regulatory tasks as well, as I've shown on this screen. And all of those things divide our attention and can distract us from delivering high quality comprehensive care, which of course, as you well know, is something we do one patient at a time. This is a study that you may know Dr. Dan Duffy, one of my colleagues in my department, and he worked with a national group on a study that demonstrated in health affairs a couple years ago that providers who are independent or rural are at a significant disadvantage in comparison to providers in large health systems with the advent of value-based payment models and the need to have technology and data scientists and epidemiologists and a full cadre of support systems to be able to measure and report quality as well as improve it and prove that you've done it. Which brings us to one of the most important issues with delivering comprehensive high quality care, and that is data fragmentation. Here's just a schematic of the way I think of healthcare data. I think of claims data as being a mile wide but only an inch deep, meaning it has an indicator of just about everything that's gone on with a patient, but it's not very deep. It doesn't have the actual blood pressures. On the other hand, in our electronic health record systems, we might have all the blood pressures, but unfortunately, real patients, they get their care in many different places potentially, and the sicker the patient, the more places they tend to be seen for care and services. And so that creates a situation where the records are scattered across a lot of different electronic health record systems in a bunch of different clinics, in addition to federal agencies and independent pharmacies and SureScripts and public health, and the list goes on and on. Then you take into account the fact that even the insurance information on patients changes. As about 20% of people change insurance every year. And so that further fragments the clinical and claims data that's available for delivering care. And so we actually quantify this data in Oklahoma and to see just how fragmented it is. And it turns out that more than 70% of patients in Oklahoma have records in 2 or more systems and places. And of course, those who have their records in just one place are pretty young, probably. They were born in a health system and they've been in that health system, and they're still maybe 10 or younger. So the bottom line is, as you well know, when a patient walks in the emergency room or comes into the clinic for the first time, there's a lot we don't know about them. And historically, we've spent our time trying to take a history to cover that base. But there's, with increasing complexity and newer technologies and treatments, it's getting harder and harder for patients to keep up with what they're taking and so on. Now, we add one chronic disease to the mix. This is just looking at diabetes patients, and suddenly fragmentation is 86%. 86% of all the patients. And if you add a second chronic disease, it's virtually 100% of patients have their data scattered across multiple systems. One of the things we're often told is, well, if you use Cerner, or if you use Epic, if you use one of those major electronic health record systems, then you're able to access data from all over the place. Well, it turns out we looked at this data also through the lens of the electronic health record system itself, and we picked the top 7 EHRs in Oklahoma. And anybody want to guess what the fragmentation was? Turns out that has the same degree of fragmentation, basically a 70-30 split, as if I were looking from one clinic or hospital system to the next. So something that is the norm and is with us and will remain with us until we figure out a way to address it is the fact that we're always dealing with a partial set of information on patients when we try to manage their care comprehensively. Now, those of you in primary care, as I am, know that we cure that problem by seeing patients and establishing a relationship over time where we deal with problems one at a time or a few at a time as we see them. But increasingly that becomes less and less possible as we're compressed on the time we have to spend with patients. And it's becoming increasingly important to have access to the records. Another issue, of course, is social needs. And we all know that taking care of a patient and helping them to get better, getting control of their diabetes, their hypertension, their depression, has a lot to do with whether they have enough food to eat and housing and transportation, whether they're in a safe home environment, et cetera. And so social needs become critically important. And they have a similar data fragmentation situation among social needs, I believe, such that, the funder, which is government and philanthropy typically, has a high level view perhaps, but individually patients or clients, in the case of social needs often, if they need one social service, they probably need multiple social services. And so what you see is, again, a fragmentation across clients and families of the data about social needs. All right, so enter MyHealth Access Network onto the stage. So MyHealth was actually founded in 2009, incorporated in 2010 by a community of actually more than 800 people participated in the initial planning process and established a mission and vision, which are mom and apple pie, but that are not necessarily typical for and more broad, I think, than many social service or social community-based organizations. In that the goal here is really to achieve health improvement, and that is health and well-being improvement for all people in Oklahoma. And our modality to do that is through the intelligent use of technology and data to provide it so that every person's health record is available where and when it's needed to make decisions about their care. And MyHealth has now grown to be a membership organization of more than 375 organizations. Pretty much everybody in healthcare in Oklahoma is a participant who's of any size. We believe we have just about 80% of all the healthcare activity in Oklahoma connected to the MyHealth system. So MyHealth is a health information exchange, and we connect the electronic health record systems and other systems, billing and claim systems, into a centralized database where we clean up the patient identities and tie the records together across multiple systems. You can see here now more than 1,100 locations statewide, more than 100,000 clinical encounters a day worth of data coming into MyHealth systems. These are where the patients live who have data in MyHealth, and this is not to say that MyHealth is connecting clinics all over the country. These are people who live in other places who over the last decade or so have received care somewhere in Oklahoma, and that data was sent to MyHealth. So MyHealth Strategy is not to deliver healthcare, is not to provide the services directly, but to be infrastructure to help you all as the clinicians and the medical decision makers and advisors to your patients to have the right information to do that in a high quality way, and to help you all and me, frankly, transition to these newer models of payment, like value-based payment models, and really, frankly, to help reduce the cost and the IT burden. So if every small clinic and every provider in every rural community has to have an epidemiologist and has to have a biostatistician to be successful in value-based payment models and to do things like pivot on a dime to respond to the pandemic, everybody's going to have to spend a lot of money on those systems, and that's just not efficient. So MyHealth is here to help bring that infrastructure to those who need it and want to embrace and use it. One thing that's critically important to understand about MyHealth, and Dr. Alexopoulos, who served as the chair of the board for MyHealth for 7 or 8 years, I believe, would agree, I think, that the governance model is the critical element to doing this kind of work, because we're essentially sharing everyone's most private and personal health information and connecting it so that those who have the permission of the patient can access those records and use them for care. And that requires having a governance that's free from commercial bias. So of course, MyHealth is a 501c3 nonprofit. And the perspectives we have on our board of directors are those who receive the care and services, the patients, the employers who pay for the care of those patients, those who pay for the care and services, the insurers and the patients themselves, and then those who deliver the care and services, that is you and me, the providers. And this board I won't spend a lot of time on, but suffice to say that pretty much everybody has a competitor on the board. Blue Cross and Community Care are there, Creek Nation and Cherokee Nation are there. OU and OSU are there. And so the idea is to maintain balance and to create an organization that's very stable and that considers policies and data uses very carefully before making changes. All right, so what are the tools in MyHealth and how do they get used? So MyHealth's core tool is a provider portal, and that can be accessed via a number of different channels. But I thought what I'd do is show it to you today because we have a new provider portal that we're very excited about. Let me just get over here to it. All right, so I'm going to sign out of this so you can see what it is. So MyHealth's provider portal, if you go to www.myhealthaccess.net, you'll see a link on the page for the provider portal. You can also go to, let me just show you the link for the production portal. All right, so if I log in, now this is a demo site and I'm looking at fake patient data, so nobody panic about PHI being exposed here, but I wanted to show you the new features and functions in the system. So if I log in, I'm presented with a patient search, last name, first name, date of birth, and it's pretty easy. And then I'm shown a list of my recently viewed patients over here on the right. And this list can be basically as long as I want it to be. One of the great improvements we've made in our systems with this upgrade to this new software platform is a better, what's called a master patient index. So the patient matching is better. If you use the old portal, you may have experienced seeing several, maybe 2, 3, even 4, 5 versions of your patient that you had to open separate records for. That's no longer the case. Almost across the board, 100% of the time, the patients are accurately matched. So there's only one record to interact with. So if I go in here and I look for a patient, then I'll be presented with usually just one, but potentially a few patients that could match that name and date of birth. And then I can click on the name and go straight into the chart. I'm presented with a challenge to make sure I'm actually taking care of this patient or have some relationship with them. I'll document network operations since I'm doing an administrative role now. And so within the chart, what you see then are, the usual, the header, the patient information, contact information for the patient. And in the situation where it's a real record, you'll see the patient's insurance up here and other important pieces of data. You'll also be able to look over here and see all the sources supplying data to this patient's record. And this is a handy way to see all the places the patient's been. You'll also see the familiar, we called this portlets before, they're now called widgets in our new system. So you can see the list of procedures and where they were done and the dates. You can see problems, vital signs. Something that's new to the system are these, we call these spark lines or trend lines. So you see the blood pressure trend line and so on. And any of these numbers that are out of range should show in red. You can see labs here also have these spark lines and a flag indicating when they're high or low. Then we have the clinical documents. We have an all results widget, which basically is sort of like a collection point for anything else that couldn't be categorized. We have new portlets, including devices, insurance, radiology, and then the immunizations, of course, which are critically important at this time of COVID. More detailed medication lists, dispensed medication, social history broken out in its own, family history, allergies, and there are several others that can be viewed as well. And any one of these portlets you can go into and look in detail. So let's say I wanted to look at the problem list. I can just maximize this and I can be shown the details of the problem list here and the code, where it occurred. And on anything in the new MyHealth system, I can click here and pull up the original document that supplied this piece of information. So this quit smoking came in here in this document. And you can see this summary document right here. This is a CCD file, which you may or may not be familiar with, but it has all the details for a particular encounter, including the progress note here, diagnoses and other pieces of information. So you really should be able to find most anything you need in this environment. Sorry, I had my button hidden behind my screen here. So if I go back to my summary page, you'll see that other widgets are laid out differently, but have a lot of the comprehensive information in them. So if I want to look at labs and maximize these, then I can actually see a table and I can see the lab and I can see the dates and times across the top. And I can simply go page by page through these until I find the results I'm looking for, or I can search for them by lab groups and see the different categories of labs and even specific lab tests within those lab groups if I want to. All right. Similar thing for vital signs. One nice additional thing we've got in this new version, you can see the vital signs here. I'm also able to graph those. So if I wanted to graph the blood pressure, then I can, this patient unfortunately doesn't have many records, but I could graph trends over time, blood pressure, pulse ox. I can apply a filter to that and so on. Go back over here. And again, there are, I can drill in literally anything in here I can drill into and find out the details. So here's a chest x-ray. I can pull it up and I can review this chest x-ray, and I can look in the summary of care that it came from to read it, as I did a moment ago. I can look over here in the radiology for these as well. And when I go up here to see, I've got documents here, and I can pull up say a progress note if I want. Here's a progress note. So you see, I can open the note, read through it, download it, print it, close it. I also have the ability to go in through the all results, and you can see a number of things listed in here, labs, radiology, and so on. I have this additional tab up here, patient results query, and that's a quick way to see what's new on the chart. And if I go into it here, you'll see that I can read individual pieces. I can print. I can see lab results in tabular form and so on. Now, one thing that's nice about this new system is the way you can configure it to your own needs. So if I go in here to my name, I can go into my user settings, and I can actually choose what things I want to see where. You see, I've chosen a 2-column view, and I've chosen to have things in this order. I can simply drag these around and move them. I can also have additional views, like I've got graphs in my tabs over here, or allergies or devices or whatever. And then what additional information I want in the patient banner is also in my control. So these are all very customizable and configurable so that the user can use it as they would like. So this is the new portal. We're really excited about it. And it's up and available 24/7. You can log in. If you are interested, I'll have some information if you're not a participant in MyHealth, so that you can contact us and become a participant. And if you are part of, say, OSU or an organization that's already a participant, then you have an account and you just need to be sent your account. So, all right. So that's the new provider portal, as I said, which we're very excited about. Let me switch back over to my presentation here and tell you about some more of the exciting things going on with MyHealth. All right. So as I said, we have these new portlets available in the system, which provide helpful information. Now, there is one challenge. I showed you this chart before, right, which indicates that maybe patient records on Oklahoma patients are in other parts of the country. And so when we have a patient that leaves, maybe is in unfortunately an accident, or is away on business or work and gets sick and needs to get care, how does their health medical record get back home to us, their providers? Well, it turns out that there are other organizations like MyHealth around the country. In fact, there are more than 80 of them. There are other health information exchanges. You see MyHealth here in Oklahoma, and then you see around the country a lot of others. And it turns out that these other organizations and MyHealth came together in 2015 to design a new model of how we would exchange data nationwide. And this is the way it works. So if you take the Health Information Exchange in Arizona, you saw Arizona itself, but now you can see on this map all the places that people who live in Arizona, or people who don't live in Arizona but have medical records in Oklahoma, just like I showed you the Oklahoma map. Same map now for Oklahoma. Let's say someone from Arizona walks into an Oklahoma emergency room here in, say, Tulsa or Oklahoma City, wherever. What happens in this model, it's called the patient-centered data home model. is that when MyHealth gets the registration message, it's called an ADT message, admission, discharge, transfer message. We open it up and we look and say, oh, this is a zip code that's not in Oklahoma. And we look around and see do we have a partner that covers this zip code? And it turns out that the Arizona Health Information Exchange actually covers that zip code, and it's over here. So we actually just package up that ADT message and we push it to Arizona. What that does is it triggers an event in Arizona where first they check to see the patient's consent. And then if there's a primary care doctor for that patient or a specialist who's subscribed to the alerts, then that doctor can be alerted that their patient is being admitted to the hospital or being seen in the emergency room in Oklahoma. And this is a real advance on models. If you've used Epic or Cerner or others, you may be aware that you can use something called Care Everywhere or Commonwealth to query for a record somewhere else. And that's a way to go get a record when you're seeing the patient and you know you need to see them. But there are no other ways to really know that your patient's being admitted without being told about it prospectively, right? And so this model, this patient-centered data home, which of course is a play on the patient-centered medical home, the patient-centered data home is set up so that the patient records get back to where they need to be, whether or not I knew that my patient was being admitted, so that I can take proactive action, get records back, let's say send the records to Oklahoma so that they don't repeat the workup. And so this is the patient-centered data home network as it stands today. And you'll see that MyHealth is actually one of the regional hubs, sort of like a Federal Reserve Bank. And we connect in Louisiana, Arkansas, and Texas to the rest of the nation through these other hubs. So basically within about a minute of an Oklahoma patient being admitted in any of these places that are connected, a provider in Oklahoma who gets these alerts, which I'll tell you about in a moment, should be aware of their patient being admitted, even if it's far away in another part of the country. Another aspect of MyHealth is that we don't just have healthcare providers and clinical data in the system, we also have claims data. And the reason we have claims data is because MyHealth sits in the middle and is a trusted third party to provide quality measurement and other services for value-based payment models. And so that creates an incentive for health plans to put their data in. So Blue Cross, Community Care, Medicaid, Medicare, now Humana are all participants in MyHealth. And on a monthly basis, generally, we get the claims data and load it to the system. So MyHealth is both a health information exchange and a voluntary all-payer claims database. So I alluded a moment ago into the patient-centered data home conversation to these ADT messages or these alerts that happen when your patient's admitted. In MyHealth, we call these care fragmentation alerts because they're events when the patient's record is going to get fragmented somewhere. And in order for somebody who's trying to provide comprehensive care to stay up to date, you need to be aware of where that fragmentation is occurring. And so the care fragmentation alerting it works for this reason. So if you've been in a value-based payment model or you've had your performance scored and told to you by a health plan, you know that there are some challenges just with knowing who your patients are. As healthcare providers, we tend to think of our patients as being the people we've seen in the last 12 months. You know, they're on our active rosters. We're actively managing a condition for them. But unfortunately, a health plan often will use an algorithm to decide who the attributed provider is. And that's based on claims data, which you probably know usually is 6 months old by the time it's usable and complete. And so health plans may attribute patients going back 24, 30 months in time. And each health plan does it differently, right? Medicare, Medicaid, Blue Cross, and so on, each have their own algorithms for determining who is the doctor responsible for this patient's care. And this can cause a problem because if I'm trying to get my breast cancer screening performance up and make sure all my patients have been screened, and I'm only looking at the people I've seen in the last 12 months, you can tell from this chart, I'm probably going to be missing many of the patients that I'm responsible for. And if you've had the experience I've had, which is to get your performance report from a health plan and look at the list and not even recognize some of the names, then you know what I'm talking about here. So MyHealth has built into it an attribution model that basically is an algorithm, and it says if the health plan attributes the patient, then make sure that all the reports to the doctor have that patient on them. And then we provide a report that looks like this. And what it shows is this is a list of patients and they're de-identified, but across the top are ways or reasons that the patient's been attributed. Like the first one is the gray is Blue Cross attributes them. The purple is Community Care attributes them. The brown is the practice claims the patient, meaning they've seen the patient in the clinic. And then there are the patient, we then attribute based on the frequency and the recentness of visits. So highest frequency in the last 12 months, 18, 24, and 36 months. And what you see here is some things that are actually quite common. For example, here are 2 patients attributed by Blue Cross to the specific doctor. And you can see that the doctor has not seen the patient yet. And you can also see that they've not even seen them in the last 24 or 36 months as well. Same thing here with 2 patients that are attributed or that are claimed by the practice, and they're not the most recent provider, but they are in the practice's list from a time ago. And then here's a patient attributed by community care that the practice was unaware of. If you're considering performance and value-based payment models and improvement over time, this is critically important to understand who your patients are. So this also drives the care fragmentation alerting. So, you know, as you know, we can't follow up a patient if we don't know they were just discharged from the hospital. And we can't follow them up after an ER visit either, or even after their cardiology visit, for example, unless we're told about it. And so this is a graphical view of what we call the care fragmentation alerts. Most organizations just get a file sent to them every morning that they can digest into their electronic health record. But this is a picture of it. And what it shows is for some home clinic, what are all the outside facilities that their patients had an encounter with in the last 24 hours. And you can see that they had a visit or an allergy or a diagnosis or a new medication. And then you can see the list of patients. And so monitoring this every day really allows you to provide comprehensive care. And if you have care managers, for example, to have them help guide which patients need to be seen, not just those who choose to be in your waiting room, but intentionally the ones whose care is out of control or who are in need of services. Catch back over that. So then there's also the possibility set up by this data of doing 30-day readmission monitoring. As you know, there are penalties that hospitals pay for readmitting patients within 30 days of the discharge for certain conditions. And this chart just basically shows that monitoring of a patient patients who are discharged in the last 30 days, everybody who's at risk for a readmission. And you can see, for example, on this chart, here are the days, here are the places they were discharged from. And here's a patient that was discharged from an inpatient setting. You can see the I there and no O's. They didn't have an outpatient follow-up, no outpatient follow-up. And suddenly they're in the emergency room with a threatened readmission to the hospital. So this is the kind of information that MyHealth can provide. It's sort of like a command and control dashboard for your panel of patients. And so this is built on top of all the data we get, which is 1.5 million messages a day for more than 1,100 locations across a wide variety of organization types. So suffice to say, if the patient's attributed to you and there's activity, it can be helpful in maintaining your population. It also helps you to know how much care and services are happening within your network and how much is happening outside of your network, so you can plan where do we need to put new locations, or what services should we hire and add to our network. And then as a provider or care manager, for example, you can drill all the way down to the individual patient level, and you can see individual patient rows here. And this Gantt chart, each row is showing an individual patient's experience of care. These are the inpatient visits for a particular population of high utilizing patients. And any one of these you can click on and drill into. So what can be done with these? Well, obviously you can do prompt follow-up from ER visits and inpatient stays, which, as you probably know, maximizes the revenue as well. It was for sure in the Medicare population to do those 7-day follow-ups. And you can also close loops on referrals. Now that we have the closed loop referral measure, fun fact, that measure was actually tested and validated here in Oklahoma, and specifically in Tulsa, with a study that we did. And in our opinion, it didn't work very well, because at the end of the year, everybody's on the phone trying to track down where their patients went and whether they got the referrals they were sent to. Well, MyHealth helps you to know whether that visit occurred or not. It can also guide care managers in a number of organizations who receive these care fragmentation reports. That's what sets the agenda for the day's work for the care managers, is to see which patients are in need of services and a touch. And then, of course, that leads to success in value-based payment models. And the next thing I wanted to talk about is something I'm really excited about, and that's our social needs screening program. I think we would all agree that social needs are the next frontier. And you recall this picture I showed you a moment ago about the fragmentation of data in social needs. It's much, even as disorganized as the healthcare delivery system is, the social services system is even more fragmented. And so in 2016, MyHealth was asked by the community to apply for a program through Medicare called the Accountable Health Communities Program. And fortunately, Oklahoma was selected with MyHealth as what's called the bridge organization, and we connect all the different components of the system together. And the job of this program is really a test that Medicare was running to see what is the value of screening for social needs and getting those social needs addressed in terms of patient outcomes, the cost of care, and utilization of care and services. And so this program focuses on housing, food, transportation, public utility needs, and safety or interpersonal violence. And so we were handed when that program was awarded, we were handed a 15-item survey. And when you're in clinic or you're in the emergency room trying to see patients, do you have time to ask another 15-item instrument of a patient? No. And sure enough, almost none of the emergency rooms or clinics that had agreed to participate in the program were willing to do it once they saw that it was going to take an extra 12 to 15 minutes per patient to screen them for social needs. So for about 6 months, we really sat and thought about what to do to address this situation. How could we get the social needs screened for without slowing down the healthcare delivery system and still get the patient's needs met? And so we came up with this process that I'm going to show you now, in which the patient registers for care. And then based on that registration event, which, as I just mentioned a moment ago, becomes an ADT message, which comes into the MyHealth system. So within about a minute, that message gets to MyHealth. And at MyHealth, the computer opens up the message and looks at the phone number, which is almost always a mobile phone number now, and generates a text message that goes back to the patient's phone while they're sitting in the waiting room. And the patient is able to consent on their phone and then complete a social needs screening right there. And fortunately, it only takes the patient 3 or 4 minutes to do it on their phone. And then we score those results at MyHealth, and we check to see if they have a health-related social need. If they don't, then that's the end of the process, and we thank the patient. But if they do have a social need, then we look in a database. MyHealth has a database of about 5,000 social services around the state, food pantries, housing shelters, and so on. We look in there and we find resources that are near where the patient lives and that are high quality. And we send a text back to the patient's phone with a link to that custom community resource summary. And then if they happen to be a Medicare or Medicaid patient and they've been in the emergency room more than once in the last year, then we also connect them to a human navigator. We have partners in the Tulsa County Health Department and the Oklahoma City County Health Department that are navigators for these patients, and they kind of act as a concierge that help that patient and their family to get the services they need over a 12-month period. So that's considered the high intervention arm. But everybody who has a need, whether they're Medicaid or Medicare or not, gets the custom resource survey. And we determined that, as from MyHealth's perspective, I mean, technically for the program, we only needed to deliver this service to Medicaid and Medicare patients. But we were, as a community-based nonprofit organization, we wanted to make sure that the uninsured and the commercially insured were not left out of this program, because we had a hunch that they would have social needs as well. And so here's the screening instrument. You can see it's pretty simple. Question, just tap on the answer to the question. And those get delivered all day, every day through organizations who participate in this social needs screening program. And often the patient completes the screening while they're sitting in the waiting room, and it gets scored and they've got their resources back. And so you can see here's a database or a map showing our resources and where they're located across the state of Oklahoma. And here's the result. If the patient does have a social need, then they get this on their phone, which is a link to a customized list to meet their needs. And as you can see, they can just click on the phone number and be talking to somebody at the day center or Boston Avenue or whatever the resource is that they need to contact. So that's really been a pretty seamless workflow. It takes no additional time on the part of the clinic or the emergency room, and it deploys pretty quickly. In addition, we've taken our community resource summaries, our inventory, and we've put it into an online system so that it's available to everybody who's a participant in MyHealth. So if you have interest in it, you can use it. I am always think of it as the black book or the 3-ring binder that the social worker always had in the emergency room or the urgent care or the clinic, wherever I was working. And that was sort of the magic book that helped me not need to do a social admission, but be able to get a patient to the services they needed. Well, those social workers and their little black books or big black 3-ring binders are fewer and far between these days. And so MyHealth offers this list, which anyone can access and utilize to find the most current resources. We have the ability to crowdsource this so that you all as participants can add new resources or let us know if something's been turned off. And so we think this is a great advancement as well in helping our community participants and providers address social needs across the state. So here's where we are with the Accountable Health Communities program. We've offered more than 1.3 million opportunities for screening in Oklahoma. And as you can see, way back in August of 2018, when we started, it was very slow. We had to work out the bugs. We had to get the workflows just right. We even had to get the messaging just right in the text message so that we had patients willing to continue and not think it was spam, for example. We also had to work with the FCC, not just with the HHS, but we had to work with the Federal Communications Commission to get a short code so that our numbers wouldn't be blocked by the carriers like AT&T and Verizon. So we got all that done. And as you can see, what's happened as a result is really a dramatic growth in the availability and use of these social needs screenings across the state. We've had 205,000 respondents. 43,000 individuals have responded with a need with over 70,000 needs, meaning most people are reporting more than one social need, which is exactly what we thought might happen, and we're glad to be able to detect those. And then among the Medicare and Medicaid patients only who are high utilizers, that is, they've been in the emergency room more than once, we've had more than 5,000 of those identified, and 4,900 of them have received navigation and had their social needs addressed. And so this is, for the first time that I'm aware of, able to paint a high resolution picture of what's going on across Oklahoma from a social needs perspective. And so what you see here is data, as far as I know, that's not available anywhere else. And what you see on the far left there are 4 bars, yellow, blue, gray, and green, that indicate the overall social needs rate. And the yellow bar is patients without insurance, which, as you might expect, have the highest rate of social needs. And then next is Medicaid patients. The gray one is the Medicare population, and the green is commercial. And most people are surprised to find such a high social need rate in the commercial population, but it's out there and it needs to be screened for. Fortunately, we've developed and provided this option now where literally any clinic or hospital health system that would want to participate in this program simply has to raise their hand and say, hey, MyHealth, come in and turn on this service for us, and we can do a little training. There's really not much lift or work on the part of the clinic to deploy this system. And then in addition, the new physician fee schedule actually that just came out for this year actually rewards providers for having done these social needs screenings and addressing them, all of which can happen in the waiting room before the patient even gets back to see the doctor. And not only that, but it basically allows you to upcode a level if you've done social needs screenings, or if you've if you've looked in MyHealth in the portal I showed you earlier, and that basically counts as checking and reviewing outside records. So that's a great opportunity, I think, in this time to optimize your billing, and because it's services you're actually providing. All right, so the last thing I'll cover here is, pandemic. MyHealth has really been central to helping to identify outbreaks and respond to this pandemic. As you might imagine, with live flowing clinical data, MyHealth also has live flowing lab data, and going all the way back to, I think it was March 8th in Oklahoma, MyHealth received the very first COVID-19 positive test, and we've been receiving them ever since, to the tune of hundreds of thousands of test results. And MyHealth continues to receive that data and do reporting on it. What you see is a dashboard that is one of dozens that we track and monitor. And MyHealth, we can stratify things by age group. We've been able to identify outbreaks in specific geographic locations like nursing homes. And, you know, of course, the state of Oklahoma, the state health department also receives these lab results, but they tend to be 48 to 72 hours older than the ones that MyHealth gets. MyHealth gets them very fresh. In fact, very early in the pandemic, I got a call from Bruce Dart at the health department, and he was concerned because he just received a call from a fire department first responder who was complaining that they had not been alerted that the patients they had just transported were COVID-19 positive. And it turns out that MyHealth had those results and was displaying them, even though the state health department and even the county health department were unaware that they needed to notify those first responders. So MyHealth becomes a really central tool in understanding the COVID-19 status of patients, helping first responders to stay protected and know whether they need to quarantine or not. And as I said a moment ago, we've even helped the state to identify outbreaks in specific towns and even down to the address, so we can identify, you know, a nursing home or long-term care facility, and even been able to see workplace outbreaks in different parts of the state as well. So, so we've done a lot with the pandemic work, and I'll just put on screen how to get involved in MyHealth, because really the engine that drives MyHealth is its participants. We've had more than 1,500 individuals engaged in participating in governance over the last decade of building and growing MyHealth, and it's obviously free and open to participation. And MyHealth will be what you make it, right? Even right down to the prices that MyHealth has to charge to be in business. That's determined by the board of directors and the governance of MyHealth. I also wanted to let you know about our COVID-19 briefing we do every Thursday at noon. You can join that. We can get the link distributed to everybody if you'd like to attend. And with that, I'll stop and take any questions and offer, of course, ways to get connected here. Do you have any questions from the audience? I'm curious, who's in the audience? Are we residents, faculty?
Both residents and faculty.
Affiliate faculty in the community as well, maybe?
Yes.
Located just in Tulsa or all over the state?
All over the state.
Oh, great.
Well, Dr. Kendrick, thank you so much for your comprehensive review of HIE and its importance at point of care and analytics. And the data source is rich, and we're just excited that you continue to mature this fabulous platform. So we wanted to make everyone aware to please use this HIE in the interest of your patients, and you can see how robust it is across paradigms of healthcare and social needs, and how it all intertwines to deliver the quality care that our patients deserve.
Great, thank you. And you know, participation in the social needs screening is obviously no cost. I see Stacy Kay's on here attending as well. She's from the office at MyHealth. You can message her directly if you'd like more information, or of course the email address I have on the screen. Everybody stay safe, and thanks very much for this opportunity to present, Dr. Alexopoulos.
Thank you, Dr. Kendrick. Have a great day. Great week.
You too.
Thank you. Bye now.